We're live, online and in person. Welcome. My name is Rob Urbito. I'm the Senior Director for Program Development at the American College of Chest Physicians. Thank you for coming to this session, Bridging Specialties, Timely Diagnosis in ILD Patients. I kindly ask that if any of you do have a question, we will have a panel discussion later in this session. If you do have a question, try to step up to the mic so that our friends online can hear your question as well. This is an exciting time for us because we just launched a toolkit, an ILD clinician toolkit for primary care related to improving the time to diagnosis in ILD. That toolkit is actually available to you as attendees of our meeting there's some kiosks in the hallway. Just look for the Bridging Specialties sign, or in your My Learning account, you can log into your chest account and engage in the toolkit that way. Excited for you to participate in that. And so that's what this session is about, is to highlight what assets are in that toolkit and what this effort is, and to see how we can partner and work together to achieve great things. I'm going to start with a little overview video. If I can figure out how to...
In a survey of patients living with interstitial lung diseases like pulmonary fibrosis, the majority of respondents said their diagnosis took 2 or more years. In fact, many times, ILDs are misdiagnosed, most commonly cardiac disease or obstructive lung disease. In the time it takes to reach a diagnosis, ILDs cause irreversible decline in lung function and eliminate therapeutic options such as lung transplantation. Available treatments can slow this progression and lessen the severity of symptoms, but can only begin once an accurate diagnosis is reached. A new initiative, Bridging Specialties, Timely Diagnosis for ILD Patients, seeks to address these delays by bringing together pulmonology and primary care experts to define a clearer, clinician-guided approach to diagnose ILDs like pulmonary fibrosis. To learn more about the Bridging Specialties program and our work to improve patient care and quality of life, visit our website by scanning the QR code.
And I would like to highlight our collaboration and true partnership with the Three Lakes Foundation. The Three Lakes Foundation has been around for a number of years, working in a number of different ways with patient advocacy, patient education, as well as working within health systems, as well as industry partners, various angles to improve the issue and time to diagnosis. And they came to CHEST because of our expertise in clinician education, and we've been working together to develop some impactful education materials that we're highlighting today. I'm Rob. You've met me. I have nothing to disclose. I would like to have our esteemed faculty introduce themselves.
Hi, I'm Mary Beth Scholand. I'm at the University of Utah, where I practice pulmonary medicine and particularly focus on interstitial lung diseases.
Hi, I'm William Lago. I am a family physician. I work at the Worcester Family Health Center and associated with the Cleveland Clinic. I'm also the medical director of their long COVID program, and I have nothing to disclose.
Hi everyone, I'm Teja Kulkarni. I'm an associate professor and director of the interstitial lung disease program at the University of Birmingham. My clinical and research interests are in improving outcomes for patients with ILD, and very excited to be a part of this initiative. I have nothing to disclose.
Thank you. I'm just going to give a quick introduction, and then we'll we'll let the faculty take over here. These are gaps and needs that you, as our CHEST audience, are fully familiar with. But I just want you to put on your cap that makes you think about how you interact with primary care and general medicine. And this is how we must think about how we frame this information to that audience and how we work together so that patients are being referred in a timely fashion and getting diagnosed. So we've boiled it down really into these three key gaps and needs. The fact that it's very rare, and so it's not often looked for, and it's overlooked. The symptoms can be confused for a variety of different diseases. The ultimate goal here is that patients who are suffering from this get to treatment sooner so their quality of life can improve. I would like to highlight, in discussing gaps and needs, the study out of Denmark in 2019, the Hoyer study, which I found really lays out the patient journey and the delays that occur in a very great way, a very effective way. Hoyer looked at, it was 204 patients, and they looked at each of these steps in the patient journey and what delays were occurring. And all the way from the patient recognizing their own symptoms to what happens in general practice. Hospital here in Denmark, that's the specialist where the pulmonologist would take over, and then eventually to the ILD center and to diagnosis. And this chart highlights really some key delays here, starting with the patient recognizing their own symptoms and a problem through general practice and the community hospital. But you'll notice even, at the ILD center, there are some significant delays here to be addressed. The target of this effort that we're talking about today really focuses on those two key big delay areas in general practice and then referral to the specialist. But I really should have highlighted the patient as well. The patient is the whole reason why we're here. And any education of the clinician, I feel like raises the bar for education to the patient as well. They will have greater awareness if their doctors have greater awareness. This is a picture of the Sanibel Island Bridge. I'm sure you're very familiar with it. This effort is called Bridging Specialties, and it's not just bridging, it's bridging between primary care and the pulmonologist, the academic pulmonologist, as well as the community clinician, but also it's between, ILD center and the community pulmonologist as well. But what I want to highlight here is the picture on the left is what the bridge looked like right after Hurricane Ian, but within days, with a little bit of sand and concrete, they had a bridge to connect that island back to civilization and be able to begin recovery. So it doesn't, building bridges is complicated. I know nothing about it, but to build enough of a bridge initially doesn't take much, some sand and concrete, and I think that applies here as well. We pulled together a multidisciplinary steering committee to focus on this effort, including chest pulmonologists, and many of them are speaking at this meeting this week, but also Dr. Lago in family medicine, Dr. Hernandez in internal medicine, as well as Jessica Glennie from Cleveland Clinic, who's an APRN. And we're recruiting more members as we speak now from other practices to help inform our efforts here. The program overall has these four key tenets. It's raising awareness, which is huge, and really, in some ways, 90% of the battle. We've done some research. We interviewed pulmonologists and primary care to dive deep into the needs and gaps. We've developed education And then, the ultimate goal here is distribution and implementation in practice for changing time to diagnosis. I'm going to hand it over to Dr. Lago.
All right, so my job is to talk about the research that we did. Basically, what we had done from April to May in this year is that we actually did surveys of primary care physicians. There were roughly 300, and they were divided almost half and half as far as family med and general and internal med physicians. And then we also did 110 practicing general pulmonologists as well. And what we tried to do was basically to see, number one, where were our errors occurring or where were our delays occurring as far as, evaluation, taking a look at our attitudes and also at a knowledge base, and then also trying to see if there were any motivators or barriers that might have made a difference as well. And we're going to dig into that in a little bit. So basically what the research did show is that there were some gaps in knowledge, obviously, and even more so, I think there was a fair amount of clinical behaviors that really contributed to diagnosis and limitation of the treatment options. And frankly, for most of these people, these delays resulted in worsening quality of their life. So how did we do it? We asked them about a sample case. It was a woman who was age 55. She had non-specific symptoms, something that in primary care we're going to see every day. So shortness of breath, particularly when they're exerting themselves, cough, exhaustion, and problems sleeping. So that's about half of my patients. And then what we did is we looked at the behaviors that came out of it, and we're going to talk about that a little bit more. So one of the things we came up in response to this, and we're going to talk about it as we go, is the toolkit. So our idea with the toolkit, as you can tell, is that it's got to be a lot of things. It has to provide education to the primary care doc, and that's where most of this toolkit is aimed. It's got to be practical, it's got to be useful, it's got to be up to date, and it has to be enough that it's going to engage people and get them involved in making a change. So what did the research shows? The first thing I think is gaps in knowledge. I think the assumption has been that as primary care docs, myself and most of my colleagues probably don't have that much knowledge about pulmonary fibrosis. Some of that is true, some of that is probably not. Actually, a study showed it was probably better than what I thought it would be. What it did show, however, that as far as breaking down some of the symptomatic clues that might lead you to pulmonary fibrosis, we weren't asking a lot of the questions that we needed to. Talking about, medications, what are we getting exposed to on the daily in both households and occupations, autoimmune diseases. And so what that came up with is a patient questionnaire. Also, one of the things that we talked about is that about half of all the patients are worked up for things like cardiac issues first. And, as a primary care doc, one of the things that I think we face every day, and this is not, we're not wanting to provide blame from the subcommittee on, myself and my colleagues, but what we find is that our jobs as primary care docs are tremendously different from most of you in pulmonary. I have colleagues that most of us are seeing patients roughly in anywhere from 10 to 20 minute blocks. Most of them come in with sometimes a dozen problems. In addition, anybody that's worked in primary care can tell you that since the advent of the EMR, we spend literally half of our visit checking boxes. So we now have things called quality numbers that have to do with, are we addressing their immunizations? Are we keeping them up to date on all their health maintenance screenings? And so a lot of it, there's very little time to dig into that. So if you looked at the various behaviors that we had, literally the thing is when you're faced with a patient who may present with, say, a mild symptom like shortness of breath, the first thing you're going to want to do is figure out what's going to kill them tomorrow. The things that are going to be later on, we'll let that go for later on. One of the other things that came out in the research is that a lot of the respondents would not be doing spirometry, they wouldn't be doing full PFTs, and certainly almost all of them would not be doing diffusion capacity as part of the initial workup. Part of that's probably thinking about it multifactorial in that obviously patients a lot of times may not have access to that testing. If you live in a rural setting, to get somewhere to have that done is almost nearly impossible. Most of them don't want to get that testing, either because of cost or they just simply don't want to go. And then obviously, as I said before, we're a lot of times looking at other issues first before we get down to the pulmonary problem. The other thing that we found is only 62% would order things like high-resolution CT if that chest radiograph is unremarkable, and still showed things like a lower lobe opacity. And 50% would order the exam if they heard cracklings on inspiration. Possibly, I would think, because they're looking at other options as far as what could be causing it. You know, one of the things that we talked about in our initial group too is that in primary care, most of us, even for evaluating things like chest x-rays or CTs, a lot of us don't look at those images. You know, in my own practice, for instance, I have patients that literally go to 6 or 8 different hospital systems. I have access to one. So I can't see those images, so I'm very dependent upon what my radiologist tells me. For instance, if the chest x-ray comes back, and if they don't see anything that they're indicating that's an issue, half the time I don't think about it, and I think that happens with a lot of my colleagues. So that also led us to come up with things like the e-learning module and the decision-making tool. One of the things we found too, as far as behaviors, is that a substantial minority, so 39%, said they would proceed with modification of their medications if they presented, so again, if somebody's already on inhaled therapy, we're going to adjust that. And that's pretty typical. And again, that still gets back to the thing that you've got 2 minutes to deal with the problem. The patient comes in, I have mild shortness of breath. It's probably not much. What can you do? They already have something like asthma or COPD. The first thing you're going to do is adjust those medications. Again, patients don't want to go for testing. They don't want to have a lot of stuff, so you make those adjustments. And again, part of it is trying to think in the back of your mind what could be in your differential diagnosis. And then finally, the less than half of the PCP respondents, roughly 46%, would refer the patient for pulmonary consult if there were pulmonary findings, and 54% would retain the patient for the initial testing or attempt treatment. So again, that gets back to the fact that I think, depending on where you practice, it may not be easy to get in to see a pulmonologist. They may have to travel, especially in the last couple of years when most of you in the room were engaged in, you know, working in ICUs or dealing with a lot of pulmonary problems. It's hard to get into your offices. It's easier for us to just try and handle it ourselves. And frankly, a lot of the patients would prefer if we tried to handle it, which I think that's one of the things we have to do, is make primary care understand that sometimes it's better to hand these folks off. And again, that also led to the e-learning module and the decision-making tool. So the patient questionnaire that we mentioned before, you know, this is something, again, for most of us in primary care, when you have a very limited amount of time, it's almost nearly impossible for me to ask all these questions. If I went through everything on this questionnaire with a patient, I'd already be halfway through my next patient's visit. So what this is designed to do is that it's a questionnaire that I can give the patient, have them fill it out, and then I can use that as a discussion piece. The other thing that it does for me as primary care is it frankly jogs my memory that, hey, you should be asking these things. So it deals with the history of their cough and their shortness of breath, things like family history, medications, hobbies, and occupational environmental exposures. And with that, I am going to turn over to Dr. Kulkarni, my partner in this project.
Thank you, Dr. Lago. So Dr. Lago told us about how we interpreted the data that we got from the survey results and what are we doing with this data. So really that's what we want to highlight today is some of the steps that we have taken so far as an initiative to bring about awareness about the disease as well as the diagnostic process. So the e-learning module has been newly launched. It is available for all the participants. And what it really highlights is being able to help you identify the classic symptoms of ILD. How do these patients present? What questions do you ask as a part of the patient history? What are the ILD specific questionnaires? And what workup can really impact the early detection of ILDs in a patient that presents with shortness of breath. What we have understood from the survey is that there are gaps, mainly because the symptoms, the initial symptoms at least, of shortness of breath and cough are so much similar to some of the other chronic conditions, cardiac conditions, COPD and asthma, which are much more common when you compare the incidence and prevalence to ILDs, and that's really where the biggest gap comes from. Apart from that, we will go through the other, each step of the gap as well, but really trying to highlight or bring ILD into the list of differential diagnosis is really where we're starting off with. So recognize how early suspicion of ILD and detection benefits the patients, and what treatment options are available are something that we want to highlight as a partnership between primary care physicians and pulmonologists. So time lost is lung lost. So that really is the key. That is what we want to highlight. Every day, every month lost from the time of symptom onset to the time that the patient is diagnosed and started on therapy is lung lost. This medications that we have currently all help us reduce or slow down the disease progression, but there is no curative therapy for any form of pulmonary fibrosis at this time. So IPF especially is progressive, the most progressive, and has the highest morbidity and mortality among all the other ILDs, and it's most certainly, if left untreated, progressive in patients. Now, the progression patterns are very variable and unpredictable. There's a lot of research that has been going on into identifying biomarkers and how do we identify patients who will, when they come back 6 months from now, show disease progression, but the field is still working on it. We're not quite there. But just understanding that the patterns are very variable and we need to have a high suspicion and understand the risk factors is something that will be highlighted here. The other factor is acute exacerbations. Unfortunately, the mortality rate when a patient with IPF gets acute exacerbation is very high. There's very limited treatment options. All our treatments that are offered to patients are based on smaller retrospective studies. And irrespective of what stage the patient is in when they have this acute exacerbation, there is a high morbidity and mortality. So there's a little bit of focus on that in this module as well. Then, what causes these delays? So each of these icons here will tell you more about what the specifics of the steps in diagnostic delays. Now, misdiagnosis is common. Again, it all boils down to like non-specific signs and symptoms, especially earlier in the disease process. Majority of the patients that we see are evaluated for cardiac conditions, treated for COPD, and then when all else fails, that is the time when further investigations are done to look for other causes. What we really want to do is put ILD at the forefront of that diagnostic process. The module also highlights some of the classic signs and symptoms to look for. There's not one particular clinical factor that we can look for and say this is IPF. So a timely diagnosis really depends on understanding all the presenting signs and symptoms and the other risk factors that are involved. The module also then highlights each of the symptoms when a patient comes in with shortness of breath or chronic cough, physical exam findings of crackles. Really what we want to try to bring awareness is listen to the patient. If you hear crackles, have a high suspicion for ILD and start the initial workup. Clubbing, oxygen desaturation with ambulation, as well as hypoxia at rest. The module also has information about the patient workup. How do you approach a patient who just comes to you with dry cough and or dyspnea with exertion? What are the physical exam findings to focus on? Do you have any signs suggestive of alternative diagnosis? Some of the questions are targeted towards looking for autoimmune conditions or exposures. And so there's details about patient workup, and then asking the patient questions, looking at patient history. Of course, medical history, when we looked at the survey results, really majority of the pulmonologists as well as primary care physicians, of course, focused on the medical history. But where there's really a gap is asking other questions regarding family history. Do you have members in the family who have had lung disease, not just COPD, but pulmonary fibrosis? exposure history, social history. Each of this history is very important in the diagnosis of ILD, and this module kind of highlights each of these components to help us understand this better. Ultimately, it is all about being proactive. Again, I cannot stress enough about increasing awareness about the disease. There's a lot that is known about COPD and asthma, but not as much about pulmonary fibrosis. I mean, oftentimes I have patients who come and tell me they've never heard about this disease before, and this is all new to them, right? So increasing awareness among physicians as well as the general population would be really important, and ultimately being proactive to help bridge this gap in the diagnostic process for ILD is what we want to focus on. And with that, I will hand it over to Mary Beth to talk about the decision tools.
Thank you very much. And so I would like to not break the microphone, first of all. There. I'd like to talk about another tool that we have in our toolkit, a different way of learning, if you will, another way to approach this by actually having people that access the learning toolkit to work through a decision tool. So we're doing this through bringing in 3 typical patients, sort of as Dr. Lago said, patients that might show up every day in a primary care's office. Each patient has some variation of signs and symptoms, and the learner can go through the patients in any order, but ultimately we'll have to see all 3 of them to kind of understand the different variations to work through the toolkit. And then based on the decisions that are made, then guidance, suggestions, learning tools are made available to them. So the patients include Harry, Michael, and Layla. And the patient's general characteristics: Harry's 66, he's shorter breath with physical activity and has a smoking history. Michael's a little younger and is coming in for a completely different reason, just to get lung cancer screening. And Layla is younger, still 35-year-old. She has reflux coughing and she's new and needs an initial evaluation. And with each patient, the learner will make decisions through multiple visits, and they'll work through a patient history. As they ask questions, it will be revealed to them in the learning tool, testing that's done, treatment, and referral. All these are decision points for the person going through the toolkit here. And what we hope is that this brings us back to the research results that pulmonologists generate a strong knowledge regarding the IPF guidelines, the use of antifibrotics is not necessarily universal. So bringing somebody through the decision process making in the toolkit will bring them to the point of deciding whether or not they want to use medication or antifibrotics. And what we learned from the tool, from our research results, bringing back to what Dr. Lago started, is that 65% of pulmonologists routinely prescribe an antifibrotic only after the patient shows progression. And so understanding this information from our research makes us understand that we want to continue with ongoing chest education on ILD. And some of that you'll see here, and some of this will be brought out in the toolkit. So the toolkit components, as we talked about, we want it to be easy to access, we want it to be relevant, we want it to be change-making. And so the components that we put together, you saw some examples of our e-learning and our decision-making, but also will include referral and diagnostic checklists, the questionnaire you saw, the e-learning module and case scenarios you saw. We also are going to add to that resources, including radiology modules on different chest x-rays and CT scans. We want to have infographics, so easily accessible visual algorithms, and an educational game so that learners can play a game and sort of do the learning through gamifying, are all additional aspects that are coming to our toolkit. So the ultimate goal, of course, is to reach people. As Dr. Kulkarni said, we really want ILD to be in the forefront of people's minds. We want to bring awareness to this. We want to reach people to think about this, and then engage them with interesting modules such as e-learning tools, games, decision-making tools to think about this and actively participate in thinking about how you manage ILD patients and ultimately driving change. And so we want to look forward in the future as we implement this toolkit, if we've had some impact, if we've changing any clinician behavior, if we're changing systems in general, if we can push hospital systems or practice patterns to change the way we interact, pulmonologists and primary care. And of course, the ultimate goal is to really change patient outcomes and make this diagnosis earlier. So stay tuned. I think that one opportunity that we want to make sure we are clear on is that there'll be grant opportunities. So pulmonologists in this audience who are intrigued by the toolkit and would like to see how that might work in their practice will have an availability for grants to partner with their primary care providers and really see if the toolkit is accessible to you. So that'll be announced sometime soon, right, Rob? We'll watch for that as an opportunity. And we really want to see that with these grants that people are implementing these toolkits, that they're actually working and we're improving time to diagnosis. So this is an exciting opportunity, I think, for many of us in practice. So, with that, I want to just really generate a panel discussion. And I think we certainly have lots of opinions on this, but I would be interested to see if anyone in the audience reactions to the toolkit, reactions to practice patterns, thoughts about what we're doing here. All right, well, I think I might start the conversation a little bit and ask Dr. Lago and Dr. Kulkarni sort of how you see the relationship as it is now between primary care and pulmonary, and what sort of thoughts you might have on how we can improve that collaboration.
I can start. I mean, one of the things I think, for me at least, sort of being the odd man out in the committee, one of the primary care guys, I've had the opportunity to actually talk to a lot of folks and frankly learn a lot. I mean, I've been in practice for 28 years, and already from having worked with these folks for probably close to a year, I've found my own practice patterns changing a bit because I'm thinking more about pulmonary fibrosis just because of what we're doing and because of some of the tools that are in there. And I think that can have a big impact. I mean, the other thing, obviously that's going to teach us that I can carry that back to primary care groups, that again, this is not to place blame. All of us can better our patient care, and education is always a good thing. And certainly if we can work as a team with our pulmonologists, that's huge. The other thing that we found is for a lot of folks, I mean, I've had patients that have been with me for, again, almost 30 years. So oftentimes, one of the things that I've found that's the craziest thing for me is that patients will come back and I will have sent them to people in the room, for instance, and trust you, that's what my intent is. You should do what they say. They will not touch a medicine until they talk to me about it. They'll talk to me about everything that you do. And so the idea of it is if we can increase that collaboration between primary care and pulmonary, I can be your advocate as far as treatment. I can help push that. If I'm better educated, my patients are better educated, that's going to get those people to treatment for you much quicker. And that makes a huge difference. One of the things we had talked earlier, I had an interaction with a patient literally this week whose family member has pulmonary fibrosis, and I knew about it, and of course said, hey, was talking to him, and they described the fact that their pulmonologist had talked to him about antifibrotic therapy, but kind of said, well, you're older, there's a lot of side effects, and the wife really wanted him to consider it. And so when I talked to him, she actually now wants him to switch to me so that I can talk him into going back in to get his pulmonologist to treat him. So those are the things that, again, if we can increase, interaction between both sides and work as a team, that helps. The other thing is that the one thing that I have access in my practice to that you don't are a lot more community resources, ability to perform palliative care, work with them on a lot of the other conditions that go along with pulmonary fibrosis. And so really, I think anything that we can do together makes a huge difference.
Yeah. Do you want to respond and then we'll take questions, or yeah?
Yeah. Just adding on to what Dr. Lago said, and oftentimes from the pulmonologist, viewpoint here, what we really want again is, the awareness. We don't necessarily need you to do the whole workup before the patient comes to see us, right? Just recognize that there is ILD here. Maybe that's something we need to look into. Listen to the patient. There are crackles, so we need further workup. Oftentimes, chest X-ray is just not enough to make, even identify ILD. If they're in early stages of ILD, a chest X-ray will not give you the answer, and you need an HRCT. But I can tell from experience that although I order HRCTs all the time, there are so many nuances in the system itself. And when our primary care colleagues are seeing, patients, like 20 patients in a half day, they just don't have the time to try to talk to insurance about getting approvals for HRCT or ensuring that it's done as an HRCT and the specifications that are recommended for the guidelines, but rather, trying to get all this workup done is not easy. And so, trying to build this bridge is really about identify that there might be ILD, that we need to think about ILD, send the patient to the pulmonologist so then further workup can be done. And from the community pulmonologist, even then more towards the academic pulmonologist, where we have resources, additional resources at an academic center to do multidisciplinary discussions, have a radiologist and a pathologist together with us on a panel to look at all the workup that has been done and come to a diagnosis. I think it is really trying to bind this together, and what we really want to do is build this bridge where we have early recognition of the symptoms to early workup to an early diagnosis.
That's great. Yes, please.
Great, thanks. So I love this initiative. I think it's really important, and I think it's long overdue. My question is the practicality of it, because as you said, Dr. Lago, you have 20 minutes, maybe 15 minutes. You have diabetes, hypertension, maybe COPD on top, and ILD is a really small component of one organ system that you deal with. So from a practical standpoint, how does this get taken up? How do we get each primary care doc to think about this particular disease state within pulmonary?
Yeah, and I think that's a good question. For me, I think part of it is just putting it on my radar. Half the time, especially, sometimes I'm shocked. I just had a patient come in that told me I've had a cough for 4 years. Well, you've seen me 20 times. You've never mentioned that. Those are very common. Or it's as I'm leaving the door, literally, we always joke about the hand on the doorknob. I'm a little bit short of breath. I don't want you to do anything, but I just want you to mark it down. And that always, I never quite get that statement. But I think what the idea of it is at least put it on my radar. That again, yeah, if I'm going to do those aggressive workups looking for cardiac stuff first, make them come back at least. And at least if you're not getting improvement with what you're doing, then do something about it. Be aware of what those workups are. As talking with the pulmonologist that I've done, make sure I'm listening. If I do anything else, listen to the base of their lungs, and if I hear crackles, send them. Those are the things that takes 2 seconds, and you may make a difference that could really prolong somebody's life, improve the quality of life, get them to treatment that much better, and that doesn't take much effort. So it's just putting it on the radar. The other thing I think that it does too is it makes us aware, for me, half of what I know about pulmonary fibrosis is what I learned 28 years ago. I mean, we don't know a lot about, in primary care, we don't hear a lot about the advancements or a lot of the research that's done. Just knowing that it's out there, one of the things that the white paper that we published that looked at it is there is a difference between general pulmonologist and primary care as far as what they think the end point is for these folks with pulmonary fibrosis. And a lot of us in primary care have a nihilistic approach that there's not much you can do. So I think knowing that there is something you can do, that again, if you're recognizing it, at least put it on your radar. Listen to the base of those lungs. If you're not coming up with anything, send them for a PFT. Consider a high-resolution CT. And if nothing else, and that's what, as we were talking about, as general pulmonologist or specialist, do you mind if I'm going to send you somebody that I'm pretty sure has it, and I may not be able to get that CT fully approved by insurance, because that's the bane of our existence as primary care, is getting imaging done. Do you mind if I send them to you with the idea, yeah, I think this might be, you know, I threw this questionnaire at them when they came in, they answered a bunch of stuff correctly, and I can hear crackles, because sometimes that may be what we've got. And so I think just making it on our radar makes a huge difference.
So thank you for this initiative, really great. I'm Jonathan Chung from University of Chicago. I'm a radiologist, right? And so I'm a hammer, right? So everything to me you can solve through radiology or imaging. But you know, in my mind, I've noticed this out in the community, even in my own practice and academic center at University of Chicago. The radiologists, even in my own section, oftentimes will undercall pulmonary fibrosis, right? Even on X-ray. So the X-ray will come in, and there's clearly some fibrosis there at the basis, right? Obviously, X-ray has its issues with contrast resolution, but they don't call it because it's not in their mind, right? You know, it's not something that they're thinking about. And so I've been, for the past 12 years out of training, I'm trying to get people in radiology to try thinking about interstitial lung disease, pulmonary fibrosis more, but it's an uphill battle. And it's because they're not quite incentivized to do that, especially for me, right? I have no control over them. So actually, the radiologists who work at your hospitals, they are incentivized to keep you guys happy. They really are, right? And our job is to help you guys take care of your patients. And so I think that something that might help would be if you met with radiology leadership and told you that this was actually something that was a high priority, and you wanted them to kind of increase their sensitivity for interstitial lung disease and pulmonary fibrosis. I found that when I've had conversations with my team, along with pulmonary medicine, and said, you know, we want you to stop undercalling pulmonary fibrosis. Start calling it, right? You see it? Call it on X-ray, right? Let's get that, and then suggest the HRCT. You know, actually, like, be a part of the team, push it forward, right? Because again, primary care, I know you guys are really, really busy. My sister's internal medicine, right? She has a clinic, and she tells me how nuts it is. And so as a radiologist, we want to help you, but we need to know what to help you with. So if you communicate with the radiology, they might be able to streamline this for you. Just a comment, not a question.
That's a really great point to consider in this initiative. Thank you.
Yeah, I agree. You know, it's one of those things, as I said before, we're very dependent upon what our radiologists tell us. And there are huge differences, he's very right. And not to discount the folks that I worked with before, but I've worked at a couple of different places in my career, and I've been with the Cleveland Clinic for 10 years. There's a vast difference between the X-ray reports I get back from the Cleveland Clinic and from where I get them from everywhere else. And I can count the number of times that I'll get one radiology report that refers to a finding that was what's unchanged from 5 years ago. Well, nobody said anything to me about it 5 years ago. So then you look back and you chase it back. And those are the kind of things that, yeah, if we involve radiology to let us know, if you tell me there's fibrotic changes in the bases and you probably should do an HRCT, 95% of us are going to do that CT. If you don't, most of us won't.
That's a great point. Yeah, please.
Excellent. I'm very excited about the initiative, and I wondered several things. Number one, when it does come out, like how will we all know? Like, I'm in private practice. I'm lucky that I'm in a community that I've very close, hey, I'm seeing your patient, Mrs. X, right now, type of communication with my primary care physicians. Or if I look at my CT and I don't like what it says because I disagree, because I pulled up the pictures myself and say, oh, well, you said it was clear, but I clearly disagree with you. Can you pull it up again and look at it? I have that level of communication. But what about my other colleagues who don't have that level of communication? And so 2 things. Number one, to go back to the question, how will the community pulmonologists be made aware of the initiative and the availability of the toolkit so they can implement it? And then once they've reviewed it, done it, then communicate with their primary care colleagues and make them aware of it so if they will have access to it as well?
Yeah, Rob, can you address that?
Yeah, great question. Thank
It's
you.
great. Thank you.
The effort is on multiple fronts. So by virtue of you being here, and anyone who's a part of CHEST will be hearing much more about this. So the CHEST community at large, too, not just if you're a member or not. Our community is over 100,000 if on social media alone. So we're exploring ways for making it increasing awareness among pulmonology, but we're also reaching into primary care as well. We're looking at a partnership with AAFP. We're working with the AMA. And then we're open to any ideas that any of you have. Like, we recognize that, the importance here is getting it into the hands, putting it on your radar, right? So any ways that we can do that, we're open to and we're looking into.
Right. And then another thing regarding the patient component, because they don't complain, or actually 50% of them don't even see a doctor, so you're never going to find them. So how do we send it out on the shock waves? Because everyone knows the latest whatever inhaler because it's on television. Your patient comes in, oh, I saw this white one with this thing on it. What's that all about? So the shock and awe, the patient information, so that they come in and say, hey, I heard this thing called pulmonary fibrosis on TV. What's that thing? And start talking to you.
Yeah, that's great information.
Hi. In response to the earlier gentleman who said, how do you handle this when you have 50 things to do when you're a primary care doctor? I think what this whole initiative accomplishes is raising awareness that there's a shift in standard of care. So I think that in my realistic mind, when the primary care doctor knows that there's a standard of care thing going on and there's a toolkit, he's not even going to look at the toolkit. He's going to know I immediately need to deal with this and send it to a pulmonary practice that deals with this. I'm overstating it a little bit, but I think that I think the important thing is that people this is going to raise awareness that you can't just ignore this kind of stuff and find out 3 years later that that you harmed a patient that you could have helped, and that's what's going to really raise the awareness. And I think it's that raising awareness that's important. I also think it's important that the practice that the patients are referred to do well. I don't know that every pulmonary practice really is good with ILD. I've heard the radiologist, his name I can't remember, from University of Chicago speak, and he's phenomenal. So he really understands how to read CAT scans in ILD. We find we have an ILD division in my practice, and we find the CAT scan may be read as very minimal peripheral interstitial markings, and our guys look at it and say, "Are you kidding? This is horrible," or vice versa. Incredibly dense reticular nodule markings throughout all, and they look at it and they say, "This is nothing." So it's the reading of the CAT scans is so inconsistent, as he stated. It's amazing. So I think I think what you guys are really doing is raising the flag, creating the standard of care and creating the awareness of that.
I think that's an excellent comment. What this initiative also wants to do, not just focus on the primary care, but also the pulmonologists, right? So the survey included results from community pulmonologists, and it was very surprising to see that there was a fairly high percent of pulmonologists who said that they would wait and watch if they diagnosed a patient with IPF, that either start therapy if they thought the patient had moderate to severe disease, or wait till the patient had showed any disease progression before they started antifibrotic therapy. But there's enough data to support that it doesn't matter how sick or what the FVC of your patient is. There is data to support starting early antifibrotic therapy, and it's not just the diagnostic part there when it comes to community pulmonologists, also disseminating information about the treatment options and the importance of early diagnosis and starting therapies.
No, I think that's a good point, and I did want to ask that question. How much do you think delays in diagnosis, and you sort of touched on this, are really that we don't have confidence in the treatment effects? Is that
Yeah, I mean,
at both your level and the pulmonologist level? Yeah.
Yeah, I mean, certainly at our level, I think, as I said, even if you looked at the initial study, there's a huge idea amongst primary care that you're not going to have that happen. And just as I said with that other patient that I just dealt with, a lot of us as primary care, there's a lot of times the patients will come back and say, yeah, they said I have this, but there's not really much that can be done. So they'll literally come back and say it was a waste of my time. And then I have to encourage them to go back and see you again. So the idea of it is that I think if even amongst the general pulmonologists, there's a little bit of pressure to at least think about early treatment and talk about those options and that sort of stuff, at least, and communicate that to us as primary care docs, knowing that I'm going to send them there and something worthwhile is going to come out of it, then that's very helpful. If, from my end, I'm looking at it that it's almost just kind of a wasted visit because we're going to send them and there's not going to be anything done, and half the time I can barely get them to leave their home, let alone drive a half an hour to see a pulmonologist, that's huge. So, making it worth their while and letting us know about the fact that there are options is a big deal.
Yeah.
So a comment on and question, I think, about what you were bringing up, and then also a comment, maybe question about this education and on the primary pulmonologist to an ILD center. But first, I think I wonder about how you ask the question, and I may get in trouble with people around here, I don't know, about the prescribing of antifibrotics. What is the standard? How many of those patients should be on antifibrotics? I think in ILD centers, all of us do shared decision-making. And none of us would say 100% of our IPF patients are on antifibrotics because it may not be appropriate for all of them. So I do wonder what the standard should be. And if you ask that question differently, how many offered antifibrotic therapy, would there be a difference in that number? Because my number certainly wouldn't be 100%. And how many of those pulmonologists are offering elements of supportive care, not just antifibrotic prescribing. To the point about the pulmonologist to the ILD center, I think that it's really important and incumbent on our ILD centers to decide what is our value. What value are we adding to the care of your patient? What value are we adding in our existing to help you in your, in your practice? We do add a lot of value. I think there is importance in getting the appropriate ILD patients to ILD centers, but I think sometimes it can be discouraging because there are long wait times and we don't always communicate the best, and maybe patients do come back because there wasn't a lot for us to add to that patient's care. But there are a lot of folks out there who think, and appropriately so, I can handle this, I can diagnose this, I can write a prescription for this. I don't necessarily need to send that patient. What else are they going to do? But transplant, clinical trials, other elements of supportive care, I think we add those values in a lot of ways, and communicating that is really, I think, important. Because we're not going to put a nail in this without all of those things. Like, we have to have patients for clinical trials to be able to further what we do. Anyways, I wonder if that is an element of this in getting the patients from those, pulmonologists to the ILD centers. That was a little much.
No, those are great points. And I don't know if, yeah, I think that's a great question. If we asked it a different way, how many were offered rather than how many are on, what would that response would be? I think that's a good question. Of course, it's in the offer, right? A lot of the details are in how we address that. So to Dr. Lago's case, if we say this is not going to help you at all, it's a lot of money and you're going to have diarrhea or, get a sunburn, they're not right. That's a very different approach than we think we can slow progression and you're going to feel better longer. Very different. But I think your point about communication is something I wanted to bring out. I don't know if I'm going to answer your question exactly, but it's been on my mind. As we talk about bridging this partnership between pulmonologists and primary care or pulmonologist ILD centers, and the fact that the patient isn't in a vacuum, they don't just have pulmonary fibrosis, they have a whole spectrum of illnesses, and each patient has their own special, treatment plan. And the fact that treating pulmonary fibrosis or interstitial lung disease is a multidisciplinary endeavor, ideas on how we can partner better with our primary care partners. And I think we touched on a little bit. You can advocate for the fact that the pulmonologist knows what they're doing, right? If we're communicating with you, but if we're not communicating for you, it's pretty hard for you to do that. And so I just was curious from the panel's point of view, and I have some ideas too, like how we might improve that, how this initiative not only gets us to early diagnosis, but improves our communication as we walk the patient through their ILD journey.
I think just opening up those channels of communication, primary care talking to your general pulmonologist, making sure that you're communicating those results back to us. If you have questions about issues, going back and forth, letting us know what you're doing. there are, anything that helps as far as education is always a good thing. And so I think opening up those discussions and those talks, letting us know as primary care that, hey, there are options available. These are the things that I think about. If you may pick up things that are more in my wheelhouse, and if that's the case, then I'll be happy to take care of those for you. And again, part of it is allowing us to work as a team. That's the big thing.
I think, I'll let you, yeah, sorry. Dr. Kulkarni touched on this. She said we don't necessarily want to own the patients, either at the pulmonary level or the ILD center level, but we want to be helpful and add value, right? So, the more we can clear those lines up a little bit, where our value is and where we don't need to be and where we do need to be, I think would be a very valuable addition to our communication as it stands now.
We can take that question.
Okay.
Kind of to build on that with the continuing education or with the toolkit now that, do you guys have any development of programs? Because now like in our system, we can do like hour lunches with continuing education where we can kind of target different groups like our primary care and talk about this and do like a 1 hour CE program, or is there anything kind of in development that can help us as pulmonologists educate our primaries?
Absolutely. I mean, that's the next step here, is to educate on the use of the toolkit in every way possible. So that's, these are all digital assets, but there's also live education that we'd love to look at. We're actually talking with a number of chapters of AAFP, and they have meetings all over the country and live opportunities to deliver sessions, as well as in hospital systems, ground rounds, et cetera. But I think that's a great idea.
And I think that's, as we consider the grant mechanisms too, how if we do those sort of things, what's the most effective way of communicating? Back to the initial question we had of how are we going to implement this into busy people's lives? How's it most effectively going to get absorbed? I think we're still trying to learn all that. I mean, that's why we have a variety of things in the toolkit to kind of see, different things work for different people, but more ideas are ideal. So, okay, I think it's time to wrap up. This has been great questions. It's 2:00 now, and we're available for more questions, more ideas as we go along. So thank you very much.